Anticoagulant agents have been developed over the last 80 years, with the goal being to develop the ideal anticoagulant. Properties of the ideal anticoagulant are a high efficacy to safety index, oral administration, rapid onset of action, low risk of food and drug interactions, fixed dosing without routine coagulation monitoring, availability of a safe antidote, and cost effectiveness. So let's see how the new oral anticoagulants perform, starting with efficacy and safety. The Einstein trial showed that treatment of DVT and PE with rivaroxaban was as effective as conventional therapy and as safe throughout the study period. The designers of the study took the risk to omit the initial period of low molecular weight heparin administration, and their decision proved to be right. Rivaroxaban was superior to conventional therapy with respect to the secondary outcome of a net clinical benefit, which was defined as a combination of thromboembolism recurrence plus major bleeding, 2.9 in rivaroxaban, 4.2 in conventional therapy. Of course, lawyers don't care much about level 1 evidence, as Dr. Katasiopoulos said, they had another party here, they're party animals. So if you look in the internet, you can find exarelto bleeding attorneys prompting patients to file exarelto bleeding lawsuit, which can make the difference between financial hardship and making ends meet. The RECOVER trial has shown that dabigatran is as safe, as effective as conventional therapy of DVT, and as safe as conventional therapy with respect to major bleeding, but safer than conventional therapy with respect to any bleeding. The AMPLIFY trial has shown that apixaban is as effective as conventional therapy and safer than conventional therapy with respect to major bleeding. And finally, the FOCUS-I VTE trial has shown that edoxaban is as effective as conventional therapy with warfarin and safer than warfarin with respect to the primary safety outcome, which in this trial was major or clinically relevant non-major bleeding. Next components of the ideal anticoagulant are oral administration and rapid onset of action. Oral bioavailability of rivaroxaban is 66% when taken under fasting conditions, and almost 100% when taken together with food. Maximum plasma concentration is reached within 2 to 4 hours. Dabigatran etexylate is a prodrug, rapidly metabolized to dabigatran with an oral bioavailability of 7.2%, which is enough to provide therapeutic plasma concentrations. Maximum plasma concentration is reached within 30 minutes to 2 hours. Oral bioavailability of apixaban is 66%, with maximum plasma concentration reached within 3 hours. Oral bioavailability of edoxaban is 51%, and maximum plasma concentration is again reached within 1 to 2 hours. Next property of the ideal anticoagulant is low risk of food and drug interactions. And indeed, these new oral anticoagulants have no food restriction and very few drug interactions. Drugs to be avoided are other anticoagulants and some antimycotics and anti-HIV drugs, whereas drugs to be used with caution are antiplatelets and non-steroid anti-inflammatory drugs. Next component of the ideal anticoagulant is fixed dosing without routine coagulation monitoring. At every stage in dabigatrans, xareltos, edoxabans, and apixabans evaluation, licensing, and marketing, the claim that there is no need to monitor drug levels has been central. And indeed, All of these trials that I have already shown, the Einstein, the Recover, the Amplify, and the Focus IVT trial, were designed with a fixed dosing without routine coagulation monitoring in the new anticoagulant arm. However, the BMJ July 2014 issue was full of editorials claiming that Boehringer Ingelheim withheld important safety analysis on dabigatran from regulatory agencies. According to the BMJ investigation, there were internal Boehringer Ingelheim's documents saying that measuring blood dabigatran concentrations and changing the dose as needed could reduce major bleeds by 30 to 40% in comparison with well-controlled warfarin. They also said that the plasma concentration should range between 48 and 200 nanograms per ml. In the same context, the EMA's initial license was conditional on the availability of an accurate test to monitor the drug. This was decided to be the hemoclot test. On the other hand, Boehringer Ingelheim claimed that this information was not shared with the regulatory agencies because the analysis did not provide a reliable prediction of patients' outcomes. Their scientists determined, and the FDA concurred, that the research does not support making dosage decisions based on plasma concentrations and conclusion based solely on science and patient welfare. In any case, several coagulation tests are affected by the new oral anticoagulants in a dose-dependent manner. The preferred assay for factor Xa inhibitors is the factor Xa chromogenic assay, whereas for dabigatran, the preferred assay is the hemoclot test. Assays that may be used in the absence of the preferred assay are the prothrombin time for the factor Xa inhibitors and Ikarin clotting test and APTT for dabigatran. Next property of the ideal anticoagulant is the availability of a safe antidote. Several specific antidotes are in development. Andexanet A is a monoclonal but enzymatically inactive factor Xa, which binds with factor Xa inhibitors, namely rivaroxaban, apixaban, and edoxaban, thus neutralizing them. Idarusizumab is a monoclonal antibody against dabigatran, whereas siraparantag or aripazine, the same thing, is a small molecule that binds with both factor Xa and thrombin inhibitors, neutralizing them both. Idarusizumab and andexanet alpha are in a rather advanced stage of development with phase 3 trials underway, so hopefully we will soon have a specific antidote. Last but not least property of the ideal anticoagulant is cost effectiveness. And until today, there have been 2 cost effectiveness analyses, both of which have reached the same conclusion, that treatment of DVT or PE with rivaroxaban is associated with significantly less cost and more quality adjusted life years. So in conclusion, the new oral anticoagulants have become valuable alternatives to conventional oral anticoagulants, and they have the advantage of high efficacy to safety index, oral administration, rapid onset of action, low risk of food and drug interactions, fixed dosing without routine coagulation monitoring, with a small question mark here, and they are cost effective. However, for the time being, there is no specific antidote. Thank you very much for your attention.